Good evening, everyone. Welcome to Rehabilitation Sciences YouTube channel. And we are here with a very interesting topic on manual therapy, overused, underused, or misused. That's a very good sound topic. And we have with us Faraz Sethi. He's a chartered physiotherapist at CAP UK, and he'll be talking about that. And Dr. Faraz, we would like to have your consent for making your lecture live on YouTube.
Yes, you have my consent.
Yeah, thank you so much. Thank you. And moderator today, Dr. Sagun Agarwal, we have, and he'll be formally starting the session today. Dr. Sagun, you can start the session now, sir.
Welcome and a very good evening to all the viewers. Rehabilitation Science Group, in collaboration with IAMR Institute, welcomes Faraz Sethi with us today. Mr. Faraz Sethi has 15 years of experience and has practiced in various countries, including United Kingdom, Russia, United States, UAE, Azerbaijan, and currently he is living and practicing in Dubai. By qualifications, he is BSc Honors, MSc, and Chartered Physiotherapist and Sports Rehabilitation Specialist. He is also associated as a medical education consultant with Breg USA. We welcome you, Mr. Faraz, and you can continue with the lecture. Thank you.
Thank you very much. Good evening to everybody in India, and good morning and good afternoon to anybody else who may be joining us from around the world. First of all, I would just like to say a big thank you to Dr. Darham, Dr. Harpreet, and Dr. Agarwal to give me this opportunity to talk on Rehabilitation Science Group. In the last month or so, I've been scrolling through the profiles, and I've listened to a few of the webinars from some fantastic high caliber individuals. And I hope today's presentation will be on that level so that we can develop some association moving forward. So what I would like to discuss with you today, sorry, before I go ahead, I want to send my well wishes to everybody in India who has suffered or is suffering with the COVID-19. I hope and I pray that things will return to normality in the next couple of months. Wishing you all well. So today's topic, a controversial topic indeed. Yes, manual therapy, is it overused, underused, or misused? Now, before I start, I would just like to put out like a disclaimer for everybody that although my presentation is evidence-based, there are a lot of aspects to it which are patient preferences, social media, which I believe in today's society is very important. Now, the role of this topic is not to upset anybody or not to think that what Mr. Faraz is saying, because he's from UK, for example, is right or wrong. We are simply opening up a discussion, and I would like people to leave thinking about what I said and how they can implement that into their clinical practice. So, just a little bit about me before we crack on. I graduated in 2006 from St. George's University of London in the UK with my Bachelor's of Physiotherapy degree. And I then went on to Edge Hill University in 2010 to complete my Master's in Sports Rehabilitation. Currently, I am residing and working in the beautiful city of Dubai. And the reason I have shown you this picture, this was taken 2 to 3 months ago during our lockdown phase. And Dubai being one of the most vibrant cities in the world, you can see here that there is not a soul on the road or not a person or car to be seen. So I thought this was a bit of a beautiful picture to show you guys, although this is not what Dubai is actually like. It's actually very, very vibrant. So me, what do I do? Currently, I am working at DX Bone and Joint Excellence Center. I'm the head of clinical physiotherapy and education. I spend 4 of my clinical work days, I spend 4 of my days doing clinical, treating patients with various musculoskeletal conditions. And I spend 1 day participating in research and preparing content for webinars, for teaching tutorials for my colleagues and other physiotherapists around the UAE. So moving on with the presentation. I would like to start my webinar with this editorial from Peter O'Sullivan in 2012. Peter O'Sullivan is a very well-renowned physiotherapist in our field, originally from New Zealand, and practiced his trade in Australia. In 2012, his editorial suggested it's a time for a change with the management of non-specific chronic low back pain. However, in the last 5 years, maybe 10 years, it seems to be that musculoskeletal pain is shifting everywhere else in the body. And the question we have to ask ourselves is, as physiotherapists, is why are so many people presenting to us with various types of pathologies? The reason is pretty simple, and this infographic will show you, because most of the patients that present to us in our clinical practice have non-specific conditions, i.e., that basically means they haven't suffered any trauma, they haven't really got any congenital or hereditary problems. These are just problems that have developed through lifestyle changes, through bad habits, and lack of exercise, most likely. Okay, yes, granted, there are a few cases that have red flags and need to be taken to the next level and referred on to senior consultants, whether they're orthopedic surgeons, neurologists, whatever may be involved in that patient's care. But like I said, non-specific conditions are what we are seeing in our clinic. And the reason we are seeing more is because we have readily access to insurance. Patients will use their insurance to at least get an opinion on what their problem is, or come in and try to utilize their insurance, because we know most likely these cases will resolve by themselves, the natural process of healing. And I like to put this photo in front of you. We are a multidisciplinary team, yes. And the reason I put this at the front, because the patient will arrive and see the physician, whether he's an orthopedic surgeon or a neurologist or a sports medicine doctor. The first person the patient will see is the physician. Why is it important that that physician relays accurate information to the patient? If they do not, and dispel them with myths, like, for example, your back pain, your disc problem will get worse with time, and you cannot do any sort of lifting or bending or twisting techniques at the moment, that patient most likely will go left towards the chronic pain route, or right towards the exercise management and getting better route. So I've just highlighted this picture because it's a process, it's a continuum of healthcare. But the first person that the patient meets has to be important, and the words used by that consultant have to filter down to the physiotherapist, so the physiotherapist can reinforce the message of positivity, self-empowerment, and getting better. And that leads me nicely on to my presentation today. Hands-on or hands-off approach to physiotherapy. Now, people may ask me on the webinar, what does that actually mean? Well, hands-on therapy means manual therapy, electrotherapy, acupuncture, any sort of therapy that you will be applying passively to the patient. Whereas a hands-off approach would be more patient education and exercise-based endurance work, or exercise-based rehabilitation work. So that is what I'm going to be discussing today. And as a manual therapist, I'm going to be using manual therapy as the hands-on approach that I'll be critiquing today. Recently, there have been people questioning whether manual therapy is really worth it, or is it actually just a waste of time? Now, I know as a manual therapist, I've used it for almost 15 years. Manual therapy for me is useful if used correctly. But let's look at the people who have questioned manual therapy. Manual therapy is a passive approach. Again, you may ask, what does that mean? Well, traditional physiotherapy, the patient comes in, they present to you with, let's say, neck pain. You would say, let's look at your movement, lie down on the bed. I will prod you in a few areas, and then I'll give you some electrotherapy possibly, and then we'll give you some exercises, and then you'll come back in 3 or 4 days and we'll repeat the same process. Passive approach, okay, where the therapist is in control and the patient is not in control of their own health and well-being, which is what we as physiotherapists should be trying to promote. wasting valuable time rather than providing self-management and exercise. We spend 5 sessions in the clinical room, and through my experience of seeing my colleagues and some other practitioners, they will spend 5 sessions in the room doing manual therapy, and they will not walk with the patient to the gym or take the patient to the hydrotherapy pool, for example. How will that patient become self-empowered? How will we change the attitudes and beliefs of that patient towards exercise rehab? We cannot simply do it through education. We have to really take them along with us and promote to them that exercise and self-management is the way and the most sustainable way that you will get rid of your non-specific musculoskeletal pain. And lastly, the specificity of manual therapy has been questioned. Palpation techniques. Can we palpate certain muscle groups? For example, the psoas muscle. When we do a spinal manipulation at lumbar spine, for example, can we be so specific to just target L3? Or when we do our manipulative technique, are we actually having a causation effect on L1, L2 or L4, L5? So specificity is questioned, and lecturers at universities will maybe tell me, well, you shouldn't be saying this to prospective students because it will put them off. But we have to be realistic here, because specificity is very, very difficult to achieve with manual therapy. Experience helps, but even myself, after 15 years of practice, I can honestly say that with palpation techniques or with manipulative techniques, I can still not be as so specific as I want to be per se. Now, questions I would like to ask maybe some of the students or some of the experienced physiotherapists on this webinar. How many times have you told a patient your hamstrings are tight? Or vice versa, how many times has a patient said to you, my hamstrings are tight? What do we tell these patients? Well, quite simply, stretch them. Or would you spend your time doing myofascial release, effleurage massage, muscle energy techniques, deep tissue massage? Okay, so this is the debate that's happening in the world. Why are we spending our time and wasting our time when we can be doing sort of exercise-based work? Similarly, my physio told me I have inactive and weak glutes. Okay, so what are we going to do with it? What are we going to do about this? Well, quite simply, we're going to activate them and we're going to strengthen them. How do we activate them? Through exercise, not through putting my elbow into somebody's gluteus muscle or putting some electrotherapy, electrical stimulation on somebody's glute. And how are we going to strengthen them? We're going to strengthen them through exercise. So these are the debates that are really, really prominent, should I say, around the world, especially in Europe, where I have graduated from. And I'd like to draw your attention to my first paper, which has been published literally 3 to 4 weeks ago. COVID-19, wash your hands, but don't erase them from our profession. Now, this is a journal that gives us an example in the last 3 or 4 months, and maybe longer in India, that we have come away from the hands-on approach because we've had to. We have not been allowed through our governments and through our health authorities to not touch patients. So we have had to adapt our approach. And we have found that patients can actually live without manual therapy. Patients can actually live without coming to see the physiotherapist if they can manage their own symptoms through education and exercise. And that leads me nicely onto this slide by Oliveira and Silva. They did a study recently which looked at people with patellofemoral pain. And what they did, they looked at a 6-week self-directed web-based care. Okay, what they found was that there was no real clinically significant differences between, at 12 weeks, between a face-to-face rehabilitation or a tele-rehabilitation. So what is that telling us? That tele-rehab is good, or manual therapy is not good, or that the general process of healing through education takes place in most individuals. And we can see 4 in 5 were at least moderately better, and 1 in 5 were completely recovered through a tele-rehab service, which we've been doing for the last 2 or 3 months in Dubai, until things opened up recently. Now, I know in India, things haven't opened up completely, And people are still doing tele-rehab or not doing as many face-to-face consultations as they would like to. But from my perspective, I would like you guys to embrace that and try to use your educational tools and your exercise rehabilitation approach to really help these patients get through this difficult time until you can start seeing them face-to-face again. And it leads me to my next question. This is a great paper from the British Medical Journal. Do physical therapists follow evidence-based guidelines when managing musculoskeletal conditions? And alarmingly, shockingly, around the world, we have to say that many physical therapists do not follow evidence-based protocols when treating MSK conditions. There are considerable scope to increase the use of recommended treatments, and we need to reduce some of the treatments that are not recommended. It almost like needs a major clean out to see what is actually beneficial for patients in the long run. Okay, we're going to pause for a video. Now, before I play this video to you, number one, it's controversial. Number two, it's animated. It is not real. Okay. Number three, it has two sort of obscene offensive language in there, which I apologize for, but you will not see it. It's just a subtitle. Okay. So I want to apologize in advance. Okay. This video has been produced by a colleague of mine in UK who is a sports physio and a shoulder specialist, Adam Meekins. Okay. Now he talks about manual therapy being a waste of time. Why? Let's have a look at the video, okay? And then we can sort of ask each other questions as we move forward. So I hope it works. And like I said, once again, I apologize for the language used.
Todo despeinado porque no me dio tiempo de nada ponerme la chancla y el bañador. Voy a la playa, ya subió la marea. Y cuando entro en el restaurante me ve el cocinero con una paellera y a ver solamente paellera. Llegaban a vuestro restaurante. Ya subió la marea. Esto, hay que hacer ahora con los dos sacos de arroz. Llama para Sevilla. Llama a Sevilla que traigo paella.
Okay, again, like I said, controversial, not real, very animated, but it gets the point across. What I'm trying to get across is that the patient attitudes and beliefs are such that we dispel these sort of theories to them that we can release, for example, the psoas muscle. The question we need to ask each other and ask evidence-based professionals is this: can you actually palpate the psoas muscle? If we look at this cross-sectional area here, you can see coming from top to bottom, the two red circles are where your psoas major muscle is. It's pretty deep. And for those of you who have been privileged to do cadaver studies and have worked through the soft tissue layers, you will realize that it's almost highly improbable to reach the psoas muscle. Yet we still in clinical practice, whether it's athletes or normal people, say, oh, I'm just going to prod in your lower inguinal region and I'm going to do some myofascial release to release your psoas tension. Okay? And for those of you who still don't maybe believe me, how about this? This is an analogy that we like to use. If you imagine you have a wallet, which is your skin and fascia layer, then we need to go through a 500-gram piece of juicy, meaty steak, which is your abdominal muscle. Then we need to get through your abdominal viscera, which is very thick connective tissue. And then we can touch the psoas muscle. So pause for a second and ask yourself, when we try to release muscles, when we try to do muscle energy techniques to try to alleviate some pain, are we actually alleviating pain? Or are we doing the opposite and causing more pain or having no clinical effect? So that's what I wanted to share with you. Again, controversial, but I think it's really important that we think about these questions, because psoas is not the only muscle that you possibly cannot palpate. If it's anything that I want the students that are joining us today to take home from my webinar, is the physio treatment pyramid, again, done by the sports physio Adam Meekins. For years and years and years, for traditional physiotherapy, how I was trained maybe 15 years ago, was all to do with get the patient on the bed, give him some electrotherapy, shortwave diathermy, laser therapy, whatever it may be. I've forgotten even the tools I use because I don't use them anymore. Okay. Then there was some manual therapy that we learned, and then we learned some exercise rehabilitation. More recently, the pyramid has shifted quite drastically, because 80% of the work we do as physiotherapists is advice and education. We build a rapport with the patient. We try to reassure the patient. We have some empathy. We try to challenge the beliefs of the patient that says, I cannot bend down to tie my shoelaces because my disc will slip. We try to challenge these beliefs and try to help them move better, as quickly and as safely as possible. Then comes a manual therapy and other forms of therapy that we have been trained to do. So what I want you guys to think, the people who are students in India or other parts of the world, is try to change your approach a little bit. Try to empower the patient more. Yes, manual therapy is important, but what is more important is that patient, after 3, 5, 7 sessions he's had with you or she's had with you, feels empowered, respects your opinion, and trusts your judgment that they will get better naturally or with exercise sustainability. So the question I would like to ask everybody is, what is manual therapy? Now, we know there are skilled hand movements intended to produce any or all of the following. Now, I'm not going to mention them. You can read them by yourself. When I was trying to find a definition for what is manual therapy from the Chartered Society of Physiotherapy in the UK, or the Australian Physiotherapy Association, or the American, for that matter, everything seems to be different. There is no unified definition of manual therapy. That's why I chose the slogan and the definition from the IFO MPT, which says promoting international, which is what we're looking to do, international excellence, and unity, which means we all sing off the same hymn sheet. Everybody knows what manual therapy is, which techniques work, and which techniques can be thrown out of the window. And this is why I like this definition, because that is what we're trying to promote and find guidelines that are recognized internationally, and not every single health authority or government authority involved with the Physiotherapy Profession Council, etc., in your own respective countries, having a difference of opinion. That is one thing that we need to change, and the global institutions and the health authorities coming together and defining what is manual therapy. I want everybody to close your eyes for a second. Okay, I want you to participate in this. Everyone close your eyes, and I'm going to read you a quick extract. Things used to be so simple when we began our careers in physical therapy many, many years ago. A patient would typically present to our clinics with musculoskeletal pain. We would identify treatable impairments in body structure and function, and we would use manual therapy and exercise to improve their function and quality of life. We truly believed it worked pretty well for most of our patients. Of course, this was in the time before we started utilizing valid, reliable, patient-reported outcome measures in our clinical practice. Once we did, many patients we thought were getting better, because they told us so, did not exhibit clinically important changes on patient-reported outcome measures. We want to please our patients, but they also want to please us. You can open your eyes now. Now, that was an extract from a patient and a physiotherapist, because for years we've just been using manual therapy and exercise. Now, to check if our treatment is evidence-based, is it actually working, we have started implementing valid protocols. like the MSK HQ healthcare questionnaire. And there's so many other protocols that we use for back pain or knee pain or shoulder pain. Okay. And this has helped us in our clinical practice, but it also has been a little bit detrimental to the way we approach our patients, because we have to get tick boxes in the patient reported outcome measures. Otherwise, the patient's not getting better. So we have to be careful how we tie these two in together. So manual therapy has individualized care. What is it? We know it's a hands-on interaction. We as therapists are told or trying to meet patients' expectations. Sometimes they're unachievable. Sometimes they're okay, we can achieve them. And the therapeutic alliance, this is the most important thing. Through empathy, through respect, through trust, through self-empowering, self-efficacy, we are trying to develop a therapeutic alliance with that patient. Manual therapy as a journey is a skill. You don't learn manual therapy techniques by watching or by reading. You have to do them. You have to feel patients to practice manual therapy. And practice leads to knowledge and experience. Okay? But as you can see, the statement from Charlie, I can relate to this quite nicely, because I've had some ups and downs with manual therapy. Sometimes I think it's the best thing I've ever learned in my university days. And sometimes I think it hasn't got too much use, or it's useless and I'm wasting my time. Okay? So it's important when manual therapy is effective. And more recently, manual therapy as Discord. What does that mean? Well, quite frankly, research results are different to those in practice. And that puts our physiotherapy profession under threat, because this hands-on, hands-off debate is missing the broader aspects of what we're talking about. Okay? It's one of those black and white things, as Eddie says. But we have to be careful. We don't want to lose physiotherapy as a profession. We want to maintain touch, because it's important. That's what we do in our profession. But the way we use it, again, has to be right and has to be clinically effective. And we know there are three paradigms for manual therapy. We have a neurophysiological response, we have a biomechanical response, and we have the psychological response to treatment. And this is highlighted in Bishop's study in 2015, because we know manual therapy has an effect on patients' pain experience. Mediating factors, biomechanical and neurophysiological. Biomechanically, manual therapy causes, we call it measurable movements in targeted tissues. We don't change so much, we get measurable movements and some structural changes in the targeted tissues. Neurophysiologically, we get a reduction in inflammatory markers and, of course, a decrease in spinal excitability. So therefore, we feel better. If we look at the future directions, which are still ongoing today and prevalent, is that additional work is needed to link the immediate changes of me pushing on somebody's spinous process, for example, and the immediate neurophysiological measures that we use in our clinical outcomes. And also, the dosing of manual therapy remains undetermined. We learn in university, I learned in university, Maitland, Mulligan, 3 sets of 30 seconds, or 3 sets of 10 repetitions on your PA movement on the lumbar spine, for example. We've all learned that through universities, and our current students are learning these techniques. But the dosage is still undetermined. And as I move through the presentation, I'll tell you why. And we know pain is a perception. It is processed in the limbic system, which has top-down moderators, which means brain to the rest of the body. And we have peripheral and central mediators as well, which can contribute to our pain experience. And that leads me nicely to my expectation paradox, which has been created by Jevna Helsa, a physiotherapist colleague in Norway. Patients come to us and they expect us to fix them. I've had patients come to me and say, Faraz, you've been recommended by such and such person, even the doctor downstairs, that I have to see you, no other therapist, because you will fix me. And when my immediate response to them is, you will fix yourself. I will guide you along the way. The important thing is that expectations of the patients are like very high, but the evidence in the literature seems to be getting less and less about what we do. So then the ladder of invasiveness gets more and more. So from physiotherapy fails. Then we have to go down the injection or viscosupplementation route. That fails. Then we have to go down the surgical route. That fails. And then we get all sorts of cognitive problems and behavioral therapies and catastrophizing thoughts that the therapy didn't work and now I'm in a worse place than I was before I even started. So the lateral invasiveness is important, but we as physiotherapists have to manage the patient's expectations. And sometimes we cannot achieve the patient's expectations. They have to be on board from you from the day one. You have to explain to them that sometimes we will not get to the expectation that you desire, but we will try our best to help you get there. Now, the reason I put this slide up is there are students on this webinar. There are students that are currently learning some of these techniques in their university undergraduate programs. Some are doing postgraduate courses like I did. I want you to stop for a second. These are all manual therapy topics. Okay, there are thousands of courses out there. Sometimes people even put a fancy name on the course and sell it. Neurokinetic flossing, for example. Okay, what does that actually mean? They're all similar in their approaches. They all have similar overlaps. But what's important is that we don't go on many courses post-graduation that are exercise prescription or exercise-based rehabilitation, Pilates-based rehabilitation. We always try to do manual therapy. And that's really interesting. I want people to think that, yes, manual therapy is important, but really you have to combine the two together to get your desired outcomes. Otherwise, one doesn't work with the other. You have to combine the two approaches together. Again, hands-on therapy. Peter O'Sullivan, I refer back to Peter O'Sullivan's post on Twitter. Hands-on is the powerful role of human touch. We cannot let go of that. It provides reassurance, it provides feedback, and it provides facilitation and provides confidence to the patient. But what Peter O'Sullivan says, and what thousands of physiotherapists around the world make mistakes doing, is communicating with the patient, saying that I am going to fix your dysfunction, or correct your instability, or realign your spinal column. We don't do that, guys. We do not do those. Those words are sort of, how can I say, they have a detrimental effect on the patient. They don't promote health and well-being for the patient. So we have to change how we understand and define hands-on approach, because in my opinion, manual therapy is optimal, but can be I'll say that again. I ate my words. Manual therapy is optional, but can be optimal for treating musculoskeletal conditions. Let's go back up there. Some of the physiotherapists may be thinking at saying, this is a bit too much pressure for me. Too much, this physiotherapist from UK is giving us too many scary thoughts about manual therapy. Trust me, we're going to look at the argument now, okay? So like I said, some therapists have said we should abandon manual therapy because it's old, outdated, and invalid, but yet we still hold on to them with dear life, that manual therapy is going to fix this patient. We need to move with current times and have new evolving management paradigms. And one of those is education, patient education, number one. Number two, exercise rehabilitation. And I want to just show you a couple of studies that have been done around the world in the last 5 years. So evidence-based current, whether it's mobilization techniques, whether it's myofascial release, whether it's spinal manipulation, all the techniques that we learn through university and postgraduate courses, these studies say that they have no effect in relation to exercise or placebo. Okay, so that's a really interesting thought. And similarly here, massage, different types of massage is what we're taught a lot in our undergraduate programs. But this study by Bender, 2019, shows minimal differences in massage. And there was no significant effects on fatigue, flexibility, strength, or jump performance. And this is just one research paper in 2019. There are lots of papers saying that massage has a very short-term lived effect, that neurophysiological response. Oh, sorry. I think I skipped a slide. So here we are. This is clinical practice. I hope the videos are working and they're not frozen. So this is me trying to do a technique to improve thoracic spine extension. Okay, so if I try to play it again, hopefully it'll play again. What are the difference between these two techniques? One is passive, therapist-led. The other one is active, patient-led. but the goal is the same. We are trying to improve thoracic extension. Sorry, I think I've missed a slide. Okay. Similarly here, manual therapy to improve terminal knee extension, doing an anterior posterior glide on the tibia. But I can do the same thing with a banded technique, banded terminal extension. The same principle. Similarly again, therapist-led, patient-led. What are the differences? Nothing. We are trying to achieve the same outcome, which is to improve ankle dorsiflexion. Whether I use a Mulligan belt or whether I use my hands to do glides or tilts or distractions, the concept, guys, is still the same. And similarly here, with lumbar spine extension flexion patterns, your PIVMs that you learn in university, your passive physiological intervertebral movements, or PAVMs, they can be replicated through exercise. And like I said, specificity of those techniques is highly, highly unlikely. So you can do the same thing and empower the patient to do these exercises by themselves. So that poses the question, what is manual therapy actually doing? And there's a word that's circulating around the European and Western market is neuromodulation, messing around with our nervous system and giving us that sense of something is changing. Whether it's a therapist that's changing that particular tissue structure, or whether it's your body responding to exercise-based therapy, or whether it's just a natural healing response. We don't know, we still don't know. But that is the question. Exercise therapy is cost-effective. Manual therapy is not cost-effective. How many patients could we see on a daily basis and keep our clinics and our hospitals and our directors happy if we did more exercise therapy? Because we could be doing more exercise therapy rather than sit with a patient for 20 minutes, putting a machine, doing manual therapy when we're trying to achieve the same outcomes. And the barriers to exercise that are common, especially, and this is from Australia, is limited funding to attend professional development, as I talked about before. We focus more on manual therapy techniques. Lack of opportunity to improve knowledge, poor access to gymnasiums. And we know manual therapy is expected by patients and our bosses, but we could be utilizing that time so much more effectively, seeing more patients, giving them better self-empowerment, education, and making more money for the clinic, which sometimes at the end of the day, business is business, right? So that is our main goal. But if you can do it through evidence-based practice, then we have achieved everything. This is the GLAD study in Australia, the Good Life Arthritis Denmark, okay? Education and exercise provided every day activities ensuring participants develop skills to self-manage their osteoarthritis. Before this program was implemented, you can look at the figures at baseline. Once it was implemented, look at the differences. 69% implemented the program, patient education, self-managing exercises in 12 months. That's a huge, huge difference, okay? And this will delay surgical procedures, delay unnecessary injections and unnecessary imaging. The debate for hands-on is interesting because Kerry suggests, oh, why are we even debating this? Because hands-on is just what we do. And if we look at this little diagram in the bottom right-hand corner, we have two options. We have threats and we have opportunities. We can either move away from touch or we can retain touch, okay? And I'm a firm believer that we need to retain touch because it's really, really important. Kerry is saying we should maybe rebrand physiotherapy as physiotherapeutic body work. So that encompasses the holistic approach, the management, the education, the exercise, the manual therapy all in one, rather than just physiotherapy. But that's up for debate and discussion. And I'd like to present to you these studies, again, within the last 5 years, that say manual therapy is excellent. Whether it's mobilization, whether it's muscle energy techniques, okay, or whether it's just simple mobilizations or massage, they have a positive effect on patient clinical outcomes. But I'm a firm believer it's how we utilize this research and how we implement them into clinical practice. I keep saying that. We have to use the right research, the right manual therapy at the right time. And this is an interesting quote that I came across on LinkedIn. I've never come across a highly skilled manual therapist who says that manual techniques don't work. I have come across plenty of clinicians who are skilled in techniques other than manual therapy, and they are the ones that often say manual therapy is useless or doesn't work. Similarly, James Schomburg, and this is for more you young student physiotherapists. I'm seeing absolute confusion by young physios when to apply manual therapy, when to use pain education, exercise management. And I strongly believe a lot of reasons why young physios don't use manual therapy is because they lack the skill and confidence, and so don't get results. And then they think, oh, it's not working, so I'm not going to do it anymore. Okay, so we have to be confident in our manual therapy techniques. And similarly here, evidence-based work, hands-off management of patients is where we are headed. Okay, but the last statement says it all. The recognition of therapeutic value of touch as one of the most qualifying professional acts of a physiotherapist is needed and guarantees patients of its best evidence-based delivery. We cannot get rid of manual therapy. We can improve our use of manual therapy, but there's no need to get rid of manual therapy and touch, because that is what physiotherapy is. That's what we're trained to do. And like I said, an empirical, pragmatic approach to manual therapy. Gone are the days where we teach 3 sets of grade 3 mobilizations on the spine. Gone are the days, okay? Because now, according to this study and a few other studies, applying theory to manual therapy results in parameters of techniques such as force, speed, direction, duration no longer being important. What is important is feedback from the patient, okay, and changes in movement quality. So if you do your techniques, stand the patient up, reassess the movement that you initially did, and see the differences. That is the way to move with manual therapy, not give dosages. Because, as this suggests, the devil is in the dosage. Practically, dosage is often constrained by patient, practitioner, time, money, resources, clinical rooms. We can't sit there and waste time with the patient, okay? But if you can gauge a response in the session, so if you do something and you can change something in the first session, and then you can give them an exercise to carry over what you've done until they come back and see you in 1 week's time, you can reverse engineer the dosage you want. So the dosage you give them in the room, they can go away and do the dosage through exercise therapy back in their own homes. That is patient empowerment. And we come down to promoting self-management. And that is what I want you guys to think about, is what we are here to do is promote self-management, okay? We need to move away from the traditional physiotherapy approach, okay? Promoting the use of self-management strategies for people with persistent musculoskeletal pain. Active therapy is better than passive therapy, and individualized, not one-size-fits-all approach is important. Change people's lifestyles and attitudes and beliefs, and stop patients catastrophizing. Because if you let them become how can I say, if they become responsible for their own health, they will not catastrophize and feel like, oh my God, this is getting worse. They will generally feel better within themselves. My conclusive message is this: manual therapy should be used as an interaction between you and the patient, as well as an intervention, okay? Think about that. Go away and think about that, because that's what manual therapy is. We are intervening, but we're also providing interaction with communication and that biopsychosocial approach with the patient to trust us. They need to trust us. We need to trust them that they will go away and do their exercise program, because if they come back in a week and they're still the same, we are wasting our time. So questions that I highlighted. Manual therapy, is it overused? I think yes, it is overused, okay? And sometimes it can be used too much, okay? And it needs to be used efficiently. Is it underused? Yes. Also, it's underused because people don't use it. People rather do electrotherapy or acupuncture or any other form of treatment that they've been taught. So sometimes it is underused and needs to be used efficiently again. Is it misused? Absolutely. And I will be a culprit to put my hand up and say, sometimes I have misused manual therapy. Okay? So sometimes we have to look at the approach, and what is the most important thing is patient expectations, patient education, self-management. If you're interested in learning more, check out these podcasts. Okay, really good, by Dr. Robert Streb, David Pope, and Professor Chad Cook. They're all available on Google Chrome in terms of podcasts. And I want you guys to listen to these. They're very short, they're very succinct. If you're driving to work, or if you have 20 minutes, 30 minutes to yourself, really listen to when manual therapy is useful and when it is not. And at the end of the day, I'm only giving you what the evidence suggests and trying to make you think about what I've said today in today's webinar. Keep calm and make up your own mind. And I just want to remind everybody that the WCPT, the World Confederation of Physical Therapy Congress, will be happening in Dubai, 8th to 10th of April, 2021. Thank you for listening.
Thank you, Dr. Faraz, for explaining well. You have emphasized onto the teamwork, and definitely the team has got a big role. Everybody from the physician to the physiotherapist to the nurse, everybody has got the role. And the another thing you emphasized onto the evidence-based practice. Definitely, we physios should be more focused onto the evidence-based practice. And but in the last, I would like to say it's a $1,000,000 question again. We should use the manual therapy or not, because it's the questions is still unanswered, because definitely the patient feel happy when we touch the patient, when we give manual therapy, because the psychological along with the neurological and the physiological effects comes up. But sometimes definitely it is being misused by the physiotherapist, as they would say by the single click we would make it corrected, and all this thing is there. And sometimes definitely it is difficult to touch the deep muscles. Okay, you cannot say, I have palpated up this muscle and all these things. But still, I would say with the development of the manual therapy, nowadays, as you said up in the whole of the world, we are using less electrotherapy. We are more dependent on to the manual part, that is the exercise therapy based, and the more onto the manual therapy is there. And we should be justified for the our manual therapy when we should use the muscle energy technique, when we should use soft tissue manipulation, or when we should use the osteopathy or the cryopractice or the manipulation is there. So definitely I would say means it's a thing is there. There should be good judgment should be there, and this judgment would be coming up with the experience. Definitely. Exactly. Yeah, definitely with the in the starting, every student would see it the fascinating, okay, manual therapy is good, but you would come to know with the time which manual therapy is good for our client is there. So
absolutely. I would just like to say that that's a very, very valid point. And like I said, we have a lot of students on this webinar, and I have learned manual therapy. And for me, it is my, we say in English, bread and butter. Without manual therapy, I would not be in the position I am today. So manual therapy is, number one, is what we do. It's physical therapy, which means touch, okay? So there's no getting away from that. But the research and what we want to try to do evidence-based is we don't want the patients to come and just come for the sake of us making them feel better for a period of time, a transition phase of 2 or 3 days, maybe 1 week. We want them to have a sustainable outcome. And the sustainable outcome is only done through, number one, education. And I'm highlighting education all the time. And number two is exercise management. And most of my patients who come in, the first session, I don't even treat the patient. It's all about gathering a history, gathering trust in the patient, trying to tell them that when I help you in these 3 or 4 sessions, you will feel better and you will go away and you will self-manage your condition without coming back and going to numerous other hospitals and numerous other unnecessary investigations. That unfortunately is the world today. You see so many people going for different investigations for no reason, for non-specific pain. So I completely agree with you. We cannot get rid of touch. It is the most important aspect of our job. The techniques will come with experience, absolutely. And I want to encourage all those students who are joining us today is really, really focus on your manual therapy techniques with your lecturers, your senior lecturers. Practice on each other, on your patients, on your family, you know, safely, obviously. But don't waste time with electrotherapy. It's one of my most important. We learn it because it's part of the curriculum. We have to learn it. But don't waste time doing electrotherapy. You're wasting 20 minutes of valuable time when you could be looking at movement patterns of somebody's spine. You can correct their muscle movements. You can really empower them and get them moving and get them back to doing whatever it is they want to do. So that will be my home-in message is, yes, manual therapy is amazing. We have to use it. We cannot get rid of it.
We have to use it. We have to justify it, and we have to find it out which manual therapy and at what time and at which intensity and which doses we should give to the patient.
Exactly. And that comes, like you said, through experience.
Because what I would say, Dr. Faraz, sometimes when we see of the evidence-based practice, what is there in the lot of researches are getting published in the Western countries, but there are the few limited patients are there. I would say in our Asian countries where the patients are there, more and more researches should come from the Asian countries, so that we could find it out what is the result is there. Because in the UK and USA, only the few patients are there, and we are having the population of the 130 crores. So I would say now the Asian countries should come forward and they should come up with the good papers, and then we could really say, yeah, manual therapy is working or not.
I think you're absolutely right. I think the population is huge in India, and the potential is huge for research. Again, we have a lot of Indian population and subcontinent population in Dubai, and a lot of the patients who come to see us, they are from that mindset of electrotherapy, manual therapy. And when I challenge their beliefs a little bit, it takes them time culturally to change, but eventually we can change them and use manual therapy efficiently and then reinforce it with exercise rehabilitation.
Yeah, because the thing is, the population of UK is the population of our capital is there.
Yeah, exactly.
So sometimes we have to go for the research and all these things. Then only we would find it out the exact result. But the conclusion is manual therapy is the foundation of physiotherapy, and it would remain. And we should focus on the exact manual therapy, and we should keep learning the manual therapy.
Absolutely. Like I said, it's my bread and butter. It is a controversial topic, but like you're absolutely right. It will remain, and for future generations to come, for physiotherapists to come. And again, want to highlight, please, students who are watching, do not give up your manual therapy techniques. Try to use them in conjunction with exercise, but really, it is one part of the cogwheel, we say. So manual therapy plus exercise plus patient education, plus advice, you have your results.
Thank you, Dr. Faraz. Thank you for your valuable time. Thank you.
You're most welcome. Take care, everybody. Stay safe.
Thank you.
Bye-bye.